You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for September 26, 2025. This week, a very bold trial in valvular heart disease, a cardiovascular prevention trial whose message is humility, dogma in VTE, venous thromboembolism, challenged, more news on GLP-1, A drugs, and a public service announcement. First is the double choice trial. Last couple of weeks, I've had some tough criticisms of trials. This week, I will start with a very nice example of evidence-based medicine done right. A German team, led by Professor Holger Thiel, presented results of their double-choice trial at the ESC meeting. This compared a minimalist approach to TAVI sedation versus standard of care. The clinical question surrounded the use of just local anesthetic and nothing else to do a TAVI versus standard of care, which included conscious sedation and local anesthesia. In Germany, standard of care has long progressed to conscious sedation from general anesthesia. Now, I find the fact that my German colleagues would do and German patients would accept a major operation such as TAVI without sedation remarkable. It speaks to the different cultures of medical practice because here in the southeastern United States, and likely most places in the U.S., sedation is used for about everything. I try to hold the line on wide-awake loop recorder insertions, but even some patients want sedation for loop recorders. Never mind TAVI. But nonetheless, the ability to do TAVI with nothing but a bit of local anesthetic is worthy of study. So that's what the Leipzig-led team did. Now, they did not just do 700 cases and then report retrospectively that everything went fine. No, they did it the proper way. They randomized half to the minimalist approach and the other half to standard of care. The primary endpoint was a composite of bad things like death, vascular and bleeding complications, infections, and neuro events at 30 days. They used the non-inferiority testing plan, which is totally appropriate. In fact, this is a classic case for using non-inferiority because the minimalist approach is clearly less aggressive. The cohorts studied looked to be a typical one for TAVI. These were age 83, 58% female, and an STS score of 4.6%. The primary endpoint occurred in 22.9% in the minimalist approach versus 25.8% of the standard of care group. The absolute difference was 2.9% better in the upper bound or worst case scenario of 2.4% worse for the minimalist approach was well within the non-inferiority margin. Other important findings included delirium, technical success, KCCQ at 30 days were all similar in the two groups, as were rates of moderate or severe AI and mean aortic valve gradients. One notable observation, only 79% of the minimalist approach stayed in that arm. 21% crossed over to the standard of care, most often due to pain, and in the as-treated arm, results were even better for the minimalist approach. Self-reported anxiety and stress during the procedure were slightly higher in the minimalist approach as expected. The authors concluded that a minimalist approach to TAVI is feasible and non-inferior to standard of care, though they note that the high crossover rate and self-reported anxiety and stress require careful patient selection, structured monitoring, and an interdisciplinary collaboration between cardiology and anesthesiology. Circulation published the paper, and I congratulate the authors for staying true to evidence-based medicine principles and studying this bold and novel approach in the proper way with an RCT. This, my friends, is the way forward for new innovations, RCTs. Our second topic is the KP Vaccinate Trial. The ESC offered another good example of using EBM in the proper way. That is, the study of electronic nudges for treatments that we want to increase patient uptake of. Authors from Kaiser Permanente evaluated the effect of cardiovascular-focused messaging on influenza vaccination uptake, and they used an RCT. First, some background. While influenza vaccine is known to vary in efficacy and data and its value in the general population or the healthy population, that can be debated. There is strong data supporting its use in patients with established heart disease. I think most impressive was the IME trial. This was a German RCT published in JAMA in 2021, which found that early flu vaccine after MI versus a saline placebo led to a statistically significant 28% reduction in a MACE composite endpoint. All-cause death and CV death were also reduced in the flu vaccine group. There have also been meta-analyses of trials suggesting flu vaccine can be considered a disease-modifying therapy for patients who have cardiovascular disease. So we want our cardiac patients to take the flu vaccine, and one way to do that is with nudge messaging. In fact, Danish researchers have shown that in their system, a letter-based nudge seems to increase flu vaccine uptake. But what can be accomplished in high-trust environments like Denmark may not scale in other systems. This is an example of how trial environment is such an important thing to consider when you are translating evidence from trials. And here we have the Kaiser Permanente Vaccinate study. Now, Kaiser Permanente is a great place for studies like this because it's like a health system within a health system. The trial included 4 million people. 4 million were enrolled into 4 groups. All eligible participants were randomized in a 1-to-1-to-1-to-1 ratio to receive combinations of 2 different messaging promoting influenza vaccine. Now, this could be a cardiovascular focused message and a usual care message across 2 points of messaging, 2 time points. These were not just cardiac patients, they were actually studying the general population, and the 4 groups corresponding to the messaging received at trial touch point 1 and trial touch point 2. And respectively, these were a cardiovascular focused nudge communication at each time point, a cardiovascular focused nudge communication, and then usual care communication, or a usual care communication and a cardiovascular focused nudge, and then usual care communications at both time points. The primary endpoint, of course, was just overall receiving the flu vaccine. So the findings, the overall vaccination rate at the end of the trial was 32.5%. Compared with participants who received 2 rounds of usual care communication, that was the control arm, those receiving cardiovascular-focused messaging at any time point had similar vaccination rates. There was no difference. The time to vaccination did not differ either. Subgroup analyses found no heterogeneity. This was a negative trial. The authors spend a great deal of time discussing their negative results relative to the positive results in Denmark. And one of the factors is trust. Trust figures in the differences. In Denmark, messaging came from a national email system, and in Denmark, people trust their public health authorities. In the Kaiser Permanente story, email came from the health system, which I am sure looks similar to the oodles of emails patients receive from their health systems. And if your health system is anything like my health system, I receive tons of worthless emails, and you just hit delete. So the impact of nudges in the Kaiser Permanente study may have been diluted by the usual e-spam sent out by health systems. On the matter of trust, I've actually had some experiences visiting Denmark, and it highlights the extreme difference in trust in public health. The authors write in their paper that trust in U.S. public health is low. This is the understatement of the year. But I think I have another reason why the KP Vaccinate study didn't really work, and it goes back to Andrew Foy's minimizer-maximizer frame, right? The minimizers are not going to care about nudges. They're not going to do anything. Maximizers, they're already signing up for flu vaccines when it's first available. And so these 2 large groups of patients are completely not affected by nudges. Well, they're not affected by PCE risk calculators or CAC scans either. This reminds me of one of the most important policy papers published in cardiology ever. And this is 2011 New England Journal of Medicine. The MI-free trial studied 2 groups of patients discharged after MI. One group got full prescription coverage with no co-payments at all for their meds, One group got their usual prescription coverage and adherence to meds was barely any higher. In the free group, it was like 36% versus 49%. So 50% of people who had free medicines were not adherent to them. And of course, there were no significant differences in MACE. And this reinforces my feeling that preventive health care is burdensome to patients. Why? Because people are busy living their lives. While we clinicians, we tend to think that patients are like robots who, if they just did every single thing we want them to do, they would live forever, free of MACE, free of cardiovascular hospitalizations. But in reality, most people don't live to be patients. Most people sense the smallness of our preventive therapies. Most people sense that the most likely result of not taking an anticoagulant for AFib is not having a stroke. Ironically, the better we get at acute treatment, the less important screening, early detection, and prevention become, right? MIs are fixed in a matter of minutes. The next day, the patient who had an MI has a Band-Aid on their wrist and a normal ejection fraction and goes home mostly unfazed. Now, make no mistake, I'm not arguing against preventive therapies. I encourage my patients with AFib to take anticoagulation if they have risk factors. I want my patients who have heart failure to take guideline-directed medical therapy. And same with my patients with coronary disease. I prescribe statins and I encourage statins and I talk to them about the risk reduction, but they're relative risk reductions. So my feeling is the simpler we make things, the more likely we are to maximize adherence to the most important therapies. As for nudges in the Kaiser Permanente Vaccinate Trial, I would argue to de-implement these things immediately, because the less we bother people, the more likely they are to respond to the important things that make things better. And so the biggest gain from the KP Vaccinate study is its monster dose of humility that it gives us. The next topic today is a trial called the HiPro trial. And I'm still doing ESC trials. There were that many good ones. HiPro was conducted at the Brigham and Women's Hospital in Boston. The clinical question was the duration of oral anticoagulation after a provoked VTE. The key modifier here is the provoked nature of the VTE. Dogma has long been that if your VTE, venous thromboembolism, was provoked by surgery or a long car trip, then treatment need only be 3 to 6 months. The Boston team, led by Dr. Gregory Piazza, challenged that dogma by randomizing about 600 patients with provoked VTE and one risk factor to apixaban 2.5 BID or placebo for 12 months. Now, randomization, of course, occurred after 3 months of treatment. The primary efficacy endpoint was recurrent VTE, and the primary safety endpoint was major bleeding, and the most common provoking factors were surgery, immobility, trauma, and acute medical illness, as you'd expect. The most common risk factors for thrombosis were chronic inflammatory disease, obesity, atherosclerotic vascular disease, or COPD, and the results of this trial are clear. Efficacy was 1.3% recurrent VTE in the low-dose apixaban group versus 10% in the placebo arm. That's a hazard ratio of 0.13 or an 87% reduction, and you don't need statistics. It's obviously statistically significant. Now, MACE endpoints were low and not different, as you'd expect. Safety, as measured by major bleeding, was 0.3% versus 0%, so 1 of 300 patients on the 2.5 milligram BID apixaban dose had a major bleed. Non-major bleeding was slightly higher in the apixaban group. 14 versus 5 patients had non-major bleeding. The subgroups were similar. There was no heterogeneity of effect, and the conclusions were that 2.5 BID of apixaban for patients with provoked VTE and one risk factor did a lot better with low-dose oral anticoagulation for a year. They have a dramatically lower rate of recurrent VTE and no substantial difference in bleeding. And this upsets standard practice, of course, which held that provoked VTE only requires 3 months of treatment. It also makes us think about the dichotomous provoked versus unprovoked framing. In this trial, the recurrence rate of VTE in the placebo arm was 10%. That rate is high. It's similar to studies of unprovoked VTE. So, of course, the trial has limitations. It was a single-center study. 2 doctors recruited most of the patients, and 1 doctor recruited more than half of the patients. This isn't a problem for internal validity, but it might make us cautious about external validity or generalizing results, especially since the placebo VTE recurrence rate of 10% is so much higher than the expected rate of about 5.8%. I say expected because systematic reviews and meta-analysis have shown that to be the usual recurrence rate of VTE in patients with a provoked VTE and one risk factor. Now, another limitation was that non-major bleeding was indeed higher in the apixaban group. While major bleeding was very, very low, non-major bleeding is certainly not nothing. Yet I think this trial should open up further studies in this space. A, we should have a replication trial, preferably a multi-center trial. B, we should further study patient characteristics in whom longer duration treatment is the right treatment. C, what about after 12 months? Should we not know if even longer duration anticoagulation is better than no treatment? I don't know. I'm asking this question. Finally, I think this data strongly supports the remarkable safety of DOAC drugs, right? Only 1 of 300 patients had a major bleeding episode. And I think we should always remember that in Averroes trial, it's one of the most important cardiology trials in the AFib space. Full dose apixaban versus low dose aspirin in patients with AFib who had a reason not to take anticoagulation. And bleeding rates in Averroes with apixaban were similar to aspirin. Pause there. Let's say that again. Apixaban and low-dose aspirin had similar rates of major bleeding, at least in the intention to treat population. I think we overestimate the bleeding risk of DOAC drugs. All right, next topic, oral GLP-1 drugs, oral drugs. 2 weeks ago, New England Journal of Medicine published results of the ATTAIN-1 trial of the oral GLP-1 drug orforglipron. Eli Lilly makes the new drug and it sponsored a trial. This was a 4-arm trial, 6, 12, 36 milligram doses of the active drug versus placebo, and the results were good. About 3,100 patients were randomized equally, mean age 45, 65% female, and mean BMI 37. The primary endpoint of body weight change at week 72 was significantly lower than placebo for all doses. It was minus 7.5% for 6 milligrams, minus 8.4% for 12 milligrams, minus 11.2% for the 36 milligram dose, and of course the placebo group lost 2%. Now, among the patients in the orforglipron 36 milligram group, 55% lost 10% of their body weight. A third, 36%, had a reduction of 15% or more, and almost 1 in 5, or 18%, had a reduction of 20% of their body weight. And of course, with body weight, markers of metabolic health all improved. Safety was as expected. Adverse events resulted in treatment discontinuation in 5.3 to 10.3 of patients in the active arm and in only 2.7% in the placebo group. Now, the degree of weight loss with this oral drug is less than that of the injectable semaglutide and tirzepatide, but it is a pill rather than an injection. And I don't have much critical to say about GLP-1 drugs. They're clearly a huge advance. No, we should not need them, right? We should be like Norway or Denmark or Sicily. But we are not like those places. I increasingly see patients in my AFib clinic who have shed 20, 30, even 50 pounds on these drugs. And if you do that, AFib likely gets better. In some cases, AFib is vanquished. So metabolic health is probably our number one public health problem today. And here are drugs that help those who have disease, who have metabolic disease. Now recall that in the SELECT trial of semaglutide versus placebo in patients with established cardiovascular disease, major adverse cardiac event reduction was 20%. And this was on top of 90% use of lipid-lowering therapy. That degree of risk reduction is similar to statins, which are considered disease-modifying. So you have to say that GLP-1 drugs are disease-modifying in patients with heart disease. Now, whether an oral GLP-1 will be better than injection remains to be seen. Certainly a pill may be easier to take than an injection. I'm happy to hear your opinion on this drug class. And I'm also happy if you have a way to get Americans to eat like Sicilians, I'm all ears. I'm happy to learn. All right, I want to just close today with 3 public service announcements from my view in clinical practice. As many of you know, I practice clinical electrophysiology in a medium-sized hospital in a medium-sized American city. It's a regular place. Here are my 3 observations from the summer. Number 1, pulse field ablation has changed everything when it comes to AF ablation. Its efficacy may be similar to thermal ablation, but it's faster, it's better tolerated by patients, and you don't have to worry about killing the patient with an atrioesophageal fistula. This is a shockingly good technological innovation from industry, and one company is clearly in the lead with their catheter and system. I have not done a thermal AF ablation in nearly a year. Second observation. If you don't have the Queen of Hearts app on your phone yet, you should get it. I covered a study on accuracy of cath lab activation on the August 1st podcast. This artificial intelligence app was far better than emergency medicine doctors and cardiologists. And I've seen this app correctly identify borderline STEMI cases. STEMI care is amazing, but there remains a group of patients with STEMI mimics or subtle cases that are missed, and for these poor souls, myocardium is lost when it need not be. Third announcement. If you are called to see a patient with ventricular tachycardia, please have in your mind to look for pause-dependent polymorphic VT related to QT prolongation. So-called torsade de pointe is common, and it's often incorrectly treated. The incorrect treatment is antiarrhythmic drugs, say amiodarone. The correct treatment is to increase the heart rate, usually with temporary pacing, and correction of the QT interval, usually by replacing electrolytes and or stopping QT prolonging drugs. You can save a life by learning to recognize and treat torsade de pointe. And that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a review. If you don't agree with something I said, please send me a message, write a comment. I like learning from the comments. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.